All right. Hello, hello, and welcome. Thank you all for being here. So, we are doing our event today with Synchron, and this is Meet an ALS Invested Company. This is an ongoing series we have where we connect with private companies that are doing work related to ALS or serving the ALS community. Today, we are here with Synchron, and we have Charles Poeppelman with us. Charles lives in Ohio. He's a licensed and nationally certified speech language pathologist. He's presented internationally on topics covering complex access systems, accessibility, and clinical training on assistive technology. We also have Chris Randby with us. Chris lives in Southern California, and his career spans neuroendovascular, emergency medicine, and breast oncology startups. He's held roles of increasing seniority across training, product management, and sales. And we don't have with us today Dr. Jeffrey Haithcock. Dr. Haithcock was planning on being with us today, but he was not able to at the last minute. But he does have a recording that Chris and Charles and we will be presenting for him to still share with you today. Dr. Jeffrey Haithcock is a full-time practicing neuroradiologist in the Dallas-Fort Worth area. Currently holds faculty appointment as clinical assistant professor affiliated of medical education at Texas A&M Health Science Center. He previously served in the role of chief medical information officer for the large subspecialized radiology practice where he's currently a partner. I'll let each of them introduce themselves. I believe Dr. Haithcock has also included a little introduction in his videos, but I will share with you also that Dr. Haithcock's wife, Kelly, was diagnosed with ALS in August of 2022. And Dr. Haithcock currently serves as her primary caregiver, along with being an advocate for ALS patients and their families. So once again, I thank you all for being here. I'd like to go ahead and pass it off to Chris and Charles. And please tell us about Synchron.
Galen, thank you so very much. And Jeff, thank you guys. It's just, it's wonderful to be with you all. I can tell you, Charles and I have so enjoyed the opportunity to connect and engage with the ALS community. And really quick, before we even get started on the presentation, just, recognition to you all. I think it's rare in the digital age to be able to establish community, care, love, and compassion. And you all are doing that. Galen, it really hit me. I think it was one of the ambassador chats when you began with grounding ourselves in the Zoom. And really, life moves so quickly, and it was so refreshing to be able to experience that moment with you all. And I think, everybody on the call was, I think, in that chat. So it's really gratifying to be on this journey with you all. And today, Charles and I are going to take you on a journey with Synchron, with brain-computer interface. And please consider this an interactive conversation. If you have questions, stop us. If you have ideas, insights, we would love to hear from them. What we hope that you take away from this presentation is that the development of Synchron's brain-computer interface is not one way. The only way that we are developing this technology is through lived experiences, with lived experiences, and by listening, engaging, and learning. So with that, again, thank you all for the opportunity to be with you here today, and we will go ahead and get started. Okay, can everybody see the screen okay?
Yes.
Perfect. So Synchron is developing an implantable brain-computer interface. Our company is based in Brooklyn, New York. The technology spun out of the University of Melbourne in the late 2011, 2012 period. And really what we've been able to do is how can we develop technology that provides independence, autonomy, privacy, and reducing caregiver burden by using someone's mind to control their digital surroundings. And we'll get into how that works in just a moment. Synchron remains an investigational device, so everything that we are going to be talking about today is not related to a technology that is commercially available, but rather one that's undergoing active clinical study. We've completed 2 in-human clinical trials across Australia and the United States, and are now actively preparing for clinical study across the world, including having recently received FDA approval to begin our next clinical trial in the United States called the INTENT study. But all that to be said, Synchron is nothing without people, nothing without the people who have come before, the people who we are engaging with now, and the people who will continue to participate in our journey moving forward. You see a gentleman on the screen here. This is Phil. Phil was part of the Switch trial and one of the first people in the world to receive a Synchron implant. The genesis of our technology also came from a person. Our founder is a gentleman by the name of Dr. Tom Oxley. And Dr. Oxley is an interventional neurologist who, again, studied at the University of Melbourne, where the technology spun out of. Early in Dr. Oxley's career, he was caring for a young man who had suffered a brainstem stroke. This gentleman was in his early 40s. He was gainfully employed and he had small children. And ultimately, due to the injury or the stroke that he sustained, he opted not to continue with life-sustaining measures. And that person never left Tom. It never left Tom that in that human being, there was the want, the need, and the interest to continue sharing their talents and their gifts with the world. But because of the nature of their injury, they were no longer able to do so in the manner with which they desired. So the question then becomes, how can we use technology to support someone who has suffered that type of injury, to support someone who is living with a neurodegenerative disease? It is Synchron's position that everyone has the right to freely express themselves, that we have the intrinsic human right to freely express your wants, interests, and desires. But sometimes in the instance of injury or disease, that right may become compromised. We are trying to build a technology that safeguards that intrinsic right for one to freely express themselves. So how are we doing that? When I move, when someone moves, when you close your hand or move your feet or shoulders, what have you, your motor cortex is firing. Your motor cortex, which is at really the top of your brain, is sending a unique, quantifiable, and repeatable electrical output, traveling down neuronal pathways to someone's musculature, allowing them to move. For an individual who has suffered a spinal cord injury, a brainstem stroke, or is living with a neurodegenerative disease such as ALS, that pathway is either blocked by nature of injury or degenerated by nature of disease. However, the will to move remains. For instance, you may have an individual who is no longer able to ambulate his or her hands, but that person thinking about or intending that activity, their motor cortex continues to send that unique, quantifiable, and repeatable signal. It simply no longer has a pathway to travel anymore. So knowing that there is a signal generated by a will to move and can no longer manifest itself physically, the question then becomes, how can we use technology to get it out of the body? And that's exactly what Synchron is attempting to do. And we do believe that there's a lot of opportunity in this space, given conventional methods that people are using to express themselves. And Charles will talk a little bit more just about that.
Yeah, no, thanks, Chris. So kind of taking a look at the current landscape, if Synchron is endeavoring to build a new technology, a brain-computer interface, one of the most important things that we can do as an organization is really dive in with both feet into ALS, into the types of technologies, the types of equipment that people living with ALS use, that their caregivers assist them with. And so unsurprisingly, we were able to find lots of different types of technologies that patients use to continue to try and remain autonomous, to make decisions, to improve their quality of life, right? So as we've endeavored to enter this space, there's different types of technologies, whether those be eye trackings, whether it be adaptive mounting equipment. But so long as the equipment exists outside of the body, it requires a high level of caregiver assistance and support, right? So the important thing to consider here is, as we were looking at current technologies that patients use, we're endeavoring to understand where there are gaps that exist. So existing assistive technologies have unreliable access points, and that if, for instance, looking at eye tracking, if you're outside of a gaze box or perhaps your eye tracker is not calibrated, you may have issues with access and remaining autonomous and continuing to make decisions. If you are not physically positioned in such a way, or maybe you don't necessarily have the exact level of caregiver assistance throughout the day, you may also be impacted in your ability to have a really great quality of life and to be able to execute different things that you need to do throughout your day. So this is helping Synchron, it's helping us to understand what are those gaps that exist today, and how can the BCI be perhaps complementary to assistive technologies. Now, as a part of that learning, we do lots of different things. So we interact directly with advocacy organizations, which you're going to hear about in a little bit, as well as, of course, our work here with ALS.Community, but also working with the clinicians that chronically work with patients living with ALS. So, for instance, you have occupational therapists, you have speech language pathologists, you have dietitians, you have pulmonologists. There's a variety of practitioners that people living with ALS often see in like an ALS Center of Excellence or throughout their care process. And so as we continue to learn into this space, we had contracted a double-blinded research survey with 150 occupational therapists and SLPs that readily look at and assess patients for assistive technologies. And unsurprisingly, in the 150 OTs and SLPs from across the United States with at least 2 years of experience working with patients living with paralysis, only 6% of them believed that these technologies fully restore autonomy and independence. So again, that's helping Synchron to understand what are those gaps that we're building towards. In addition to that, we worked with the ALS Association on their focus survey. So every couple of years, the ALS Association, and there are other organizations that do these sorts of surveys with people living with ALS, but trying to understand different factors that are impacting perhaps a patient's quality of life or their ability to have privacy, or what their quality of care looks like. And what the survey found was that 75% of people living with ALS with upper limb impairment lose access to their assistive technologies multiple times of the day. So there's sort of an unwritten rule with adaptive technology, in that oftentimes in research literature, you have these technologies are looked at in their best case scenario, in that you have a patient, they're positioned, and what are their words per minute, let's say. Well, that's not real life, right? And that people lose access throughout the day for lots of different reasons. Or if you're going to be needing your system in one room and then you need to move it to another room, that's another way that you may lose access, right? 47% in that focus survey, 47% of people living with ALS with severe impairment are unable to quickly notify their caregiver at least one time during the week. So looking at not only those small socialization, the small periods of communication that are important, greetings, saying good morning, saying good night, but also those emergency situations that may occur that are very important for us to be able to communicate out, right? So looking at that as well in the survey. So what are we building here? What are we working to fulfill in that gap? So what Synchron has built is a brain-computer interface. So a BCI, which is a short term for it, is a prosthetic that reads intent to move, and directly sends those signals outside of the body to a computer. Okay, so you have that physical pathway that's been disrupted, as Chris stated, either through an injury, or in this case, a disease. So that motor neural pathway is degenerating with regards to ALS. And so what we're doing is effectively we're creating a brain-controlled keypad or a mouse, bypassing the physical impairment, the physical pathway, and creating a new digital one, directly thereby allowing a patient, just through thought alone, to control external devices by thinking about moving.
I think we have a couple of questions or comments in the chat, so we can go ahead and bring that up. I'd love to hear why the 6% actually think current tech fully restores independence. Interesting take. Appreciate that, Galen.
Yeah, so I'd say on that question mark, we of course, this is a broad survey, right? So I think that what we find is that you have some therapists that maybe have maybe much more advanced training. So one of the things I'll even share from my field is, generally speaking, SLPs and OTs don't have an enormous breadth of training and assistive technology. Sometimes it may be reduced at university to a single modality or a single class. So this sort of encompasses that there is immense specialization, as well as there's a lot of you could say clinical generalists, and that they have to cover a wide scope, everything from in my perspective, everything from swallowing to looking at dietary modifications to speech and articulation, as well as, of course, being able to work with technologies and recommend certain technologies for, like, let's say, a speech generating device. So there's a lot of specialization. So you may have some professionals that are much more inept to say that, hey, this technology really works in the patients that I use it with. However, what we've been able to see throughout Chris and I's time really diving into the ALS population is that real world use in the home may look drastically different than use in a clinic, right? So trying to get outside of the clinic, into the community, into the places where BCI is going to be used is absolutely imperative. So that's what we are endeavoring to do as an organization. We're endeavoring to see, how is technology used in the home? Where does it fail? And how can we perhaps maybe fill the gaps there, right? So I think Chris is going to take more of a deep dive into what it is, this BCI, and the different parts of it that we're building.
Thanks so much, Charles. And again, guys, when you look at the field of interventional cardiology or even endovascular neurosurgery, more and more procedures are being done not through open methodology, but through either the arterial pathways of the body or the venous pathways of the body. Consider these the brain's natural highways or the body's natural highways to reach different elements of the body, not through an open manner, but through the blood vessels themselves. That's exactly what Synchron is doing. We are using the brain's natural highways, in this case, its venous system, to interact with the brain with our brain-computer interface. The system is separated into 3 different components. On the top right-hand corner of your screen, you see the stentrode. The stentrode is a stent-based electrode array. There are tiny electrodes interspersed across the body of that stent. The stentrode is connected through a pliable lead wire to the transceiver. The transceiver is very similar to a pacemaker battery. This powers the stentrode and sends the neural data that's being captured from the motor cortex, again, with those intended movements or that thought of moving, and it sends that neural data out through Bluetooth to a computer. Our brains are beautiful, and they can certainly be noisy. The computer is looking again for those unique characteristics that we previously calibrated into switches based on, again, say someone thinking about closing their hand, that will represent differently than someone thinking about pressing on the gas. So when we think about access, the stentrode is inserted into the patient's body through the jugular vein with a microcatheter, a small tube that's threaded up the jugular vein through the superior sagittal sinus, which is your largest vein in your brain and the draining vein for the motor cortex, and then precisely unsheathed within the walls of the vein over the motor cortex. Synchron is unique in that there is no open brain surgery required for this procedure. Again, everything is done endovascularly through the venous system. In our most recent US trial, the COMMAND study, the time it took to deploy that stentrode again through the venous system was roughly 20 minutes. So when you think about scale, when you think about speed, and certainly these all merit additional study, but we are very enthusiastic with some of the early data that we are seeing across the first 2 clinical trials that Synchron has performed. Again, one in Australia and then one in the United States. The transceiver is inserted through a pocket. So again, quite similar to a pacemaker being inserted. This is a rechargeable battery. So at the end of the day, the patient will wear almost like a scarf or a throw pillow, if you will, that has a paddle recharger that is placed gently over the transceiver for roughly 10 to 15 minutes to recharge the battery before use for the next day. And then again, the exciting opportunity with this technology is the chance to build a multitude of different switches commensurate with different motor movements. So again, think of scenarios where closing one's hand may represent a different switch than pressing on the gas, so to speak. Or let's say, to Charles's point, the need to notify a caregiver that someone's in urgent need. What if we're able to build a caregiver alert through the thought of 2 discriminate movements in succession? There is a wealth of opportunities through this technology And again, everything that we are driving to is how can we build a technology or technologies that drive independence, autonomy, privacy, and they reduce the burden on a caregiver. You know, Charles and I have been very privileged to be able to interact with a variety of people across the world living with neurodegenerative diseases. And we had a conversation with an individual around changing the thermostat. And this person is losing the ability to thermoregulate themselves. And they had talked about the opportunity to change their thermostat. While to some it may seem pedantic, but they've become incredibly reliant on their caregiver to do so. And they communicated to Charles and I that that's governance and dominion over my own body, under my own volition, and how valuable that is to that particular individual. Charles talked a little bit about social isolation and loneliness. And again, we are driving to create technology that hopefully decreases that and leads people to continue sharing their gifts on their own terms. Now you're going to hear a little bit from Dr. Jeffrey Haythcock. And again, we've been extremely grateful. We met Dr. Haythcock last year at the ALS Nexus conference when he was visiting with his wife, Kelly. Dr. Haythcock has now become a consultant for Synchron and advises us on a variety of educational opportunities. And you'll be able to hear from him, someone who has performed endovascular procedures. Dr. Haythcock has not performed any Synchron-related procedures, but what we hope you'll be able to glean is a perspective from a 30,000-foot view, the differences between open neurosurgical intervention and minimally invasive surgical intervention. Dr. Haythcock will then share his experiences, he and Kelly, living with ALS and his experiences as a caregiver as well. So Galen, before we play the video, I just want to make sure we can go to the chat quick too, if there are some additional questions or comments.
I think Kathy had a great question just with regards to how do we think about interweaving BCI technology into current technology. And I had put some information into the chat for Kathy, but it's an excellent question because it's like we don't want to build in isolation, right? This is what it means to build with the community, to understand what are the current, I believe it's Team Gleason that states that until there is a cure, technology is a cure. It's been a philosophy that we've tried to carry forward as an organization, having been a collaborator with Team Gleason since 2022. So we are absolutely locked in with that, Kathy, and it's a great comment. Yeah.
Thank you for sharing, Kathy.
Is the transceiver internal, Chris? That's another question that Chris H. had.
Chris, wait, the more handsome Chris, I was waiting for you to ask a question, sir. Great to see you. Yes, the transceiver is implanted underneath the skin, right around the clavicle. So to that point, historically, again, brain-computer interface is not necessarily a new field of study. And you may see imagery or videos with an individual who has a surgically implanted brain-computer interface with an apparatus fixated to their skull. With Synchron, you would never know that someone had their brain-computer interface. We are designing something that's wholly internalized and, again, never touching the brain matter itself. There is a saying in neurosurgery that the brain is never the same when it touches air. And whether that's true or not, we do believe that by engendering this through a minimally invasive approach that has the opportunity to be as least intrusive to the person, the patient's anatomy as possible, with the opportunity for efficacy and speed too, because the patient's not undergoing open brain surgery for Synchron's BCI. Great question, Chris.
Thanks, Chris. I have a question myself. I'm curious if you can speak a little bit to if there are any advantages to this minimally invasive internal approach versus some of the external approaches.
It's a great question, Galen, and I think to that point, Dr. Haythcock's commentary will help give a little bit of background on that as well. So maybe that's actually a good segue. Let's have Dr. Haythcock explain the differences between minimally invasive and open neurosurgical intervention, and then we could talk a little bit more about your great question too.
All right, sounds great. I'll go ahead and play this video from Dr. Haythcock. All right, I believe you all are seeing the screen here.
Yes, yes, we are.
Awesome.
Thank you so much for your time. My name is Jeff Haithcock. I'm an interventional neuroradiologist in the Dallas-Fort Worth area. I had connected with Synchron at the ALS Nexus conference not too long ago, as they showed up on my radar because I work with a lot of healthcare startup companies. I have a few patents on medical devices, and I had come across an article about this company that was developing a endovascular device that was a brain-computer interface. So that kind of intrigued me, and we were fortunate enough to connect together. They had asked me briefly to talk about the differences between traditional surgery and minimally invasive surgery with respect to brain-computer interfaces, which I'm going to do right now. So when you hear something that requires surgery, it can mean different things to different people. And basically, I put this into two categories. One is open surgical intervention, which in the terms of neurosurgery or endovascular neurosurgery involves removing a portion of the skull to gain access to the brain and or the blood vessels in this region. With that, recovery is typically longer. It can be anywhere from a few days to a week, depending on what you had done. The other option is what we call minimally invasive endovascular surgery, and that's my field, which involves making a small, approximately 2 millimeter incision in the leg and using the artery or the vein in the leg to gain access to the brain. With these procedures, no matter what you're having done, the recovery is typically shorter. Usually you can go home the same day or the next day, depending on the procedure being done. I wanted to illustrate the difference between surgical treatment and endovascular treatment of cerebral aneurysms and how it relates to brain-computer interfaces. So I have a few cases here I just want to highlight. Here's an example of treating a cerebral aneurysm. What's an aneurysm? It's an abnormal outpouching of a blood vessel in the brain. When they get to be a certain size or shape, they're prone to rupture and it can be fatal. So patients that present to me or my colleagues or people in my field are usually given two options for repair of these aneurysms. One is traditional neurosurgical clipping of the aneurysm. That's what we're illustrating here. This illustration shows a craniotomy or a hole in the skull. That a piece of the skull is temporarily removed. It's done under general anesthesia, obviously, and the surgeon has access to the blood vessels where they place this vascular clip across the neck of the aneurysm to occlude it from the circulation. This is what an aneurysm looks like. So that's one way of treating an aneurysm. The other way is what's done in my field, which is endovascular or interventional techniques, which would be considered minimally invasive surgery. And with this technique, we use the artery in the leg as a highway to the brain. So we have small catheters and wires that kind of navigate up. This is what's called the common femoral artery in the leg, and we use it to go around the chest, around the heart, through the neck, and into the brain, and put these little coils on the inside of the aneurysm to cause the aneurysm to clot off and not rupture in the future. So that's becoming kind of the standard of care for most cerebral aneurysms these days. The recovery is quicker, as I had mentioned. You get a little Band-Aid on your groin, typically go home the next morning, and the recovery is much smoother. Here's another example of a minimally invasive procedure for something called dural sinus stenting. There's large veins on the surface of the brain that drain the blood flow, and occasionally, for any number of reasons, they become narrowed and cause symptoms like papilledema or swelling of the optic nerves, severe headaches, things like that. So for this procedure, we do the same thing as the aneurysm, except for accessing the venous side or the outflow. So we're using the common femoral vein here. We gain access to that vessel. We put a little sheath in there, which is like a 2 millimeter straw, so to speak, a one-way valve, and we use that to put our tools through there to gain access to the brain. These green arrows kind of show where the narrowing is of the blood vessels, and that's what we plan to treat. This illustration here shows how this is done. So you're looking through the right eye. In this illustration, you have what's called a guiding catheter on the inside of the vein here. You can't feel this. Typically, these patients are not under general anesthesia. They're typically under conscious sedation, meaning half awake, half asleep, similar to like undergoing a colonoscopy or a minor procedure. So through this guiding catheter, we put what's called a microcatheter across the stenosis here. And we use this, what's called self-deploying stent, which is a metal scaffolding to expand and open up that narrowing and restore the venous outflow. And we'll talk a little bit more about that briefly. What does that have to do with ALS and brain-computer interfaces? Well, basically, that venous procedure is similar to some of the BCIs that can be placed in or near the surface of the brain. The Synchron device specifically, as I think was mentioned earlier in the presentation, is something that goes on the inside of the blood vessel on the top of the brain and is placed via minimally invasive techniques. Other companies have different strategies for their brain-computer interfaces. They're done surgically, meaning that a portion of the skull needs to be removed and the brain electrode or the brain-computer interface device, which consists of multiple electrode arrays, has to be placed either on the surface of the brain or near the surface of the brain. So it's a different procedure and a little bit more invasive, so to speak. Synchron is one, as you know, of a few companies ever growing in the space. There's multiple companies getting into the BCI space, and all of them have a little bit different strategies in terms of their devices. Minimally invasive endovascular techniques, like the way the Synchron device is placed, is something that's been done for other conditions for many years. We've been doing this probably 30, 40 years now, putting stents on the inside of veins. Obviously, cardiologists have been doing it on the inside of the heart for many years. The procedure time is typically pretty short. A lot of venous interventional procedures in the brain can be done quickly in under 30 minutes from the time you puncture the groin to the time you're done. The recovery is pretty quick, usually a day or so, and the risk profile overall, depending on what you're having done, is decreased as opposed to traditional surgery. If you have interest in BCIs, how it may benefit you or a ALS patient that you're taking care of, there's tons of information online. I know there's information at the end of this webinar too. Thank you for your time. I hope this kind of gave a whole high-level overview of the differences between the open surgical intervention and minimally invasive surgery, at least how it relates to BCIs. Now, Chris and Charles had asked me briefly to talk about my caregiving experience, and this may have been mentioned in the overview of the presentation, but I am the primary caregiver for my wife, who is also a physician, now retired because of her disease. She was diagnosed with ALS about 4 years ago at age 46. Like a lot of patients, she had very nonspecific but slowly progressive symptoms over about 6 months duration for her. The average time from symptom onset to the actual diagnosis of ALS for most patients is around a year because everything else has to be excluded. So her story is no different than a lot of people. She had limb onset disease. Just to complicate things, at the time of diagnosis, our children were ages 5, 10, and 12. When she was having these slowly progressive symptoms, they kind of knew something was wrong. Kids are very intuitive. They know more than I think what we give them credit for. So that added a level of complexity to our situation that, unfortunately some people have to deal with too. I've been the primary caregiver for my wife for about 4 years now. It's been exhausting physically, emotionally, mentally, as I mentioned below. I had to give up my endovascular practice at the time so I can do remote work from home, which has been a blessing. So I'm able to work almost full time at home, which has been great because I can step away and take care of her needs and still work almost full time, which has been great. I just wanted to put 1 or 2 slides about my opinion about caregiving for ALS patients. So in terms of our situation and in terms of my opinion, the hard parts for me in terms of this disease are the constantly changing needs over time. As you're well aware of, whatever symptoms you have today may change overnight. They may change a month from now. They may stay the same for a year or so. It's so hard to plan as you have disease progression over time. So I know for me, the constant uncertainty, not being able to make definitive plans, a month or 2 or even a year in advance has been quite a challenge. I like to know exactly what's going to happen and when, have an idea of what my wife's needs will be, and there's really no way to tell. It's all just a guess. The other part that's pretty hard for me and I think for our family is trying to maintain a sense of normalcy for our children. They've been dealing with this for about 4 years now. They're a little bit older. I have two teenagers. For better or worse, they have access to the internet. They can look up all the gory details about ALS, and they can also find a lot of helpful information too. So helping them sort through that and pointing them in the right direction has been great. It's been a challenge, dealing with their friends, teachers, parents. People have a lot of questions. At the beginning of every school year, there's new families, new teachers, and I feel like we have to rehash our whole story over again and kind of explain to them what's going on. So that's been a little bit of a challenge. Accepting help from others has been a challenge. I strongly prefer to be self-sufficient and take care of my own needs and our family's own needs. With this disease, it's almost impossible to do. It's hard to work full time or near full time, take care of my wife and make sure my kids are accounted for. I also take care of my elderly parents who I moved here right before my wife was diagnosed, before we knew what was going on. It was unrelated to this. So we have our hands full. So we need help when needed. I've learned to be a better person in terms of accepting help when offered, whether, no matter what type of help that may be. I know social isolation is kind of an issue. It's hard to get up and go. You have to get ready, you have to plan, you have to bring equipment. We love getting out of the house. We try to go to all of our kids' events. However, it's a challenge. A lot of times we end up just staying home instead of going out just because it's easier. So there's a degree of social isolation, I know, for me and my wife, and we try to do everything we can to prevent that. This slide says the easier parts. There's really no easier parts with ALS, but there are some things that I try to remind myself to be grateful for, including things like on-demand delivery of groceries, medical equipment, things like that. You can get almost anything delivered to you within, a day or so, sometimes even within an hour. Something that didn't exist 20, 30 years ago. So that has been great. Instead of me having to step away and go to the store and pick out stuff, it's so much easier just to get it online, which is great. Having telehealth appointments has been wonderful. Most of my wife's needs at this point can be taken care of remotely. We still go to ALS clinic every 3 months, but anything between clinic appointments can be done via the internet, which has been great. We live relatively close to an ALS clinic, about 45 minutes to an hour away. I know for a lot of patients and their caregivers that's not the case, but there are a lot of ALS multidisciplinary clinics in major metropolitan areas scattered around the country. So that's kind of been a blessing for us in disguise. There's so many ALS organizations that can provide, patient caregiver resources, including loaner equipment, generally used equipment you can keep, support groups. It seems like there's just a plethora of online resources, and we try to take advantage of everything we can. I threw this in here just briefly. This probably looks like most of your houses if you are an ALS patient or a caregiver. We have the permobile wheelchair, that's her primary wheelchair. We have a backup wheelchair I didn't take a picture of. We have a sit to stand device. My wife can still stand up a little bit in this device carefully. We have this fancy called New Products shower chair that some other ALS family donated to us. It's been a godsend. We had to build this teak shower floor to keep it even with the rest of the bathroom. We have a Hoyer lift that was donated from one of the ALS organizations. We have a eye gaze device that my wife is learning to use. She still has her voice for now, but is training on the eye gaze device. That's been great. We have a BiPAP machine that gets used intermittently as needed. We have a bidet with a seat riser for the toilet seat. That's been wonderful. We have this fancy OB adaptive feeding device, which I thought we didn't need until we had it, and it has been wonderful. We take it with us. They're kind of expensive. Insurance doesn't cover it, but I found a used one online. I'd recommend you do the same. Really enjoy having that. Summary of caregiving, at least in terms of my experience, there's so many challenges with this disease. It can be overwhelming at times. Most days for me, it feels like the house is on fire. But despite all the chaos, all the grim statistics, I think there's many reasons to remain hopeful. As was talked about earlier today, there's these new adaptive technologies that are coming to market, along with new FDA-approved therapies, including like tofersen for the SOD1 mutation for the genetic variant. That's been great. Hopefully, there's some other stuff in the pipeline. There's multiple trials going on right now, which I'm sure most of you are aware of. I know my wife was part of the Healy ALS platform trial. She was on regimen F a couple of years ago. I think they're further down the alphabet now, but at least there's drugs in the pipeline being tested quickly, and hopefully something will show some promise. And there's also so many nonprofit organizations now. There used to be just a handful. There's a dozen of them out there that can offer support to patients and their families, just to really make things easier for everyone. Thank you again for your time. I really appreciate it. Sorry I couldn't be there in person. I had a work conflict, so hopefully this recording came across okay. Please reach out to me anytime. I think my email is included in the presentation. I know my phone number is probably plastered all over the internet. If there's anything I can help in any capacity, answer any questions, please let me know. Thank you again.
We've been so grateful for the chance to get to know Dr. Haycock over the past several months, and again, just so appreciate although he couldn't be here with us today, him sharing some of his experiences and his journey with his wife, and we hope that you found that valuable too. So with that, guys, we will bring this presentation home. We are just about wrapped up here. And thank you guys so much for the questions too in the chat. We really appreciate it.
Yeah, with regard to Dr. Haycock and a lot of the work on the procedural side for Synchron, while it's definitely it's first in category, it's the first time that we're bringing electronics into the brain in this sort of way, but that foundation of science and stenting is very, very well practiced, as Chris had stated in the cardiology field. I'm sure it's very common language for someone to say, hey, I know somebody that went and got a heart stent, right? So stenting is very, very well known, and stenting is done in the brain with regard to many procedures every single day all over the world. And so while that's excellent and that's great that we're able to do this and to innovate and bring this technology into the brain in this manner, what the FDA has sort of stated to Synchron is, okay, so you all can get these digital motor outputs, these DMOs outside of the brain. What is the clinical benefit of reading the brain, decoding the signals? And that's where we really get to this concept of digital actions. So this isn't conceptual, but a digital action is really what we want to do with any given piece of technology. So we're wanting to communicate in an app. We're wanting to control our lights. We're wanting to make maybe a healthcare decision, shop online. Everybody does that, right? Play games, have other related activities like managing our finances. Most banking, I believe 80 to 90% of banking is now done online throughout the entire world. So these are tasks that we don't think about so much as everyday management tasks that we do digitally, but most tasks that we do are actually digital. And so this is sort of our idea state in that this isn't conceptual anymore. So we've facilitated this across 10 people in Australia and the US to build what are called digital motor outputs into digital actions for a variety of different tasks. So whether that's, in this case, you have one of our patients, Mark, completing different tasks here, like managing his lights, his sounds in his house, being able to use a communication app to be able to shop and really to maintain as much independence and autonomy and really executing the self-volitionary tasks that ALS slowly starts to take away. And so whatever we can do to maintain and empower the patient is what we're looking to do. So next slide. So, and we've come a long way. So we've already sort of stated those two previous clinical trials that we've had. We worked with 10 patients. Really, the primary outcomes that we've been tracking so far have been related to safety, right? We need to have really good safety, and we've maintained the highest levels of safety. And that through our 10 patients, we've had no significant adverse events related to the neurology, related to placing the stent road, related to the vascular system. And as we move forward, safety is going to continue to remain a top priority for our patients, but also we're getting to this next phase of our clinical development where we talk about a concept called efficacy, which is clinical benefit. It's the utility. It's you got a BCI for what reason? So when it comes to that, Chris went over these already, but that's helping us to understand, okay, how does a BCI impact a patient's ability to make decisions throughout the day, not at just one moment, but at any given moment throughout the day. So being able to maintain autonomy, functional independence throughout a variety of different tasks, as well as privacy. Privacy is something that isn't really discussed much, or at least in much detail like other modalities like independence is. But privacy is something that ALS does take away from people. Actually, folks that are working through any level of paralysis, when you have a caregiver that necessitates some of your life tasks, you're losing some of that autonomy and you're losing some of the privacy that comes with autonomy. So understanding how can a BCI protect a patient's data? How can it allow a patient to maybe communicate more privately in ways that right now don't exist, with pretty much all text having to be written out on a computer screen, anybody can access it, right? So what are ways that we can look at privacy? And there's been a plethora of organizations, and we want to be able to share this on a single slide. There's actually more organizations listed here. So this is a combination of partners, of close collaborators. Every single one of these organizations is an organization that Chris and I have had the opportunity to get to know, to communicate with, to learn from over the past 2 years. And it has been an immense learning journey for our organization. These organizations have helped us from everything on how do we think about structuring a clinical trial? How do we think about asking questions? How do we think about our language that we use when we're talking to patients and people living with ALS and their caregivers? So there's all amounts of learning that go on, not only from a product standpoint, but from a language, from a mission standpoint to how do we work within the community, how do we work with the community. So I think lastly, I wonder if you want to bring us home, Chris, with this message from Graham. I'll put it into the chat as Chris reads the quote, but Graham was a wonderful, wonderful person. He happened to write a book called Telepathy for Beginners. I'll put a link into the chat. You can look at it on Amazon if you'd like, but it is, as Graham talks about his experience. But go ahead, Chris.
Yeah, we began this presentation earlier in the slide deck with an image of Phil and commenting that Synchron is nothing without people, and people like the people that are part of the ALS community, people like each and every one of you. So we want to thank you so much for being where you are, for sharing your time with us, because it's so valuable. And we are so grateful that you've chosen to either spend this last hour with us now, or you're spending this hour with us at another time convenient for you. Because again, as we seek to safeguard someone's right to freely express themselves, we can't safeguard that in a vacuum. We can't safeguard that in a lab doing experiments. We can safeguard that in community by listening, by learning, and by engaging. And to Charles's point, so Graham Falstead was the first participant, the first patient to have the Synchron BCI system. And he said, "It has been exciting to participate in an endeavor that has shaped science fiction into medical fact. I'm extremely proud to be the first of what will be many beneficiaries of this technology." And to Charles's point, Graham published a book, Telepathy for Beginners, a few days before his passing. And Graham's spirit continues to live on in Synchron and will continue to do so, as has Phil, as has every other individual that has helped shape this journey, whether they have participated in clinical studies, shared their wisdom, shared their insights. We're so grateful for that. And to that point, we'd welcome you, if you haven't already, to join Synchron's BCI community. This is a great place to stay informed relative to current happenings to the company, whether that is participating in paid market research, sharing your perspectives or opinions, or joining one of our registries. If you live in the United States, the Intent Registry is now open. We would encourage you, if you're interested in learning more about that clinical trial, to join the Intent Registry, which again can be accessed either through the QR code on screen or by visiting synchronbci.com. If you live in Australia, the Focus AUS trial is also open, that registry, and you are able to access that registry by, again, visiting synchronbci.com. So again, especially To everyone on the call, Galen and Jeff, thank you both so much. You continue to pour such positive energy, love, and kindness through the ALS community. And that, directly impacts Charles and I's, not just our work, but our lives. And really want to just share with you all how much we've enjoyed being with you here today. And we certainly don't hope that this is the last time that we have the chance to interact with you all. So thank you so much. Happy to take any questions or comments at this time, and we'll go from there. Thanks again, everybody.
Wonderful. Thank you so much, Chris, Charles. Appreciate you being here. We do have just 1 or 2 more minutes left. There were a few comments in the chat. I believe most of the questions that I'm seeing have already been addressed since they've been placed in there. I wonder if anybody has any questions alive still. There is one question from Kathy. Would Dr. Haithcock's wife be a candidate for this technology?
A great question, Kathy. And I think to your point too, Brian, Synchron doesn't have a hand in terms of the clinical trial participants that are chosen for the intent study. But what you can do is join the intent registry, and then joining that will connect you to an independent clinical third party that will participate individuals through a pre-screening and screening process. So that can be accessed via synchronbci.com. And Kathy, to your point, that's not necessarily territory for Charles and I to comment on. But really, the clinicaltrials.gov does include some of the inclusion and exclusion criteria for intent. And one of the areas that we are interested in connecting with and learning from are individuals living with bilateral upper limb paresis.
Could I follow that up? Could I follow that up real quick so I make
Sure.
the point clear? So is this more geared to people with bulbar onset or sporadic onset? And that's kind of why I asked if Dr. Haithcock's wife would be a candidate, because her onset was sporadic.
Yeah, it's a great question, Kathy. And I can tell you, too, across the patients who have participated in our previous clinical trials, we've really had a variety of disease presentation. We've had some individuals who maintain verbal capacity through their journey with the Synchron BCI device, some individuals who had previously received mechanical ventilation before receiving the Synchron BCI device. So it's really been a diverse patient subset to that. To your point on the intent clinical trial, we are again interested in a variety of patients. So individuals who are verbal, who are nonverbal, but again, the one of the core inclusion exclusion criteria is related to an inability to lift their arms against gravity. Charles, I don't know if there's anything additional that you'd like to comment in terms of that IE criteria for intent.
Yeah, I was going to say what Chris and I can do is we can drop the clinicaltrials.gov link in here as well, so you can take a look at it. I was going to mention, Kathy, so we did not specifically include the onset form of ALS as a part of our IE criteria. To Chris's point, it's more related to current levels of function with regard to the upper limbs. And that's just with regard to our device is really looking at replicating that hand function in a digital sense, because as it just so happens, much of the tasks digitally that we do with our hands. So that's really what we're after. And to Chris's point, there's different, you could say, cohorts of patients that we would want to understand, because obviously the ALS journey is a progressing one. It changes. So it's very important for us to learn, let's say early onset, what does a patient want to do with a BCI and how that might change over the course of time. So yeah, all that to say, we don't designate whether it's bulbar or sporadic onset. And again, I think Chris just put the clinicaltrials.gov link, and all the IE criteria is there, Kathy. And you're more than happy to follow up with you in additional questions too.
Absolutely.
Well, it's just great news to hear that for a trial, bulbar onset has not been excluded. And I'm sure you guys understand that very well. So thank you.
You got
of course,
it.
our pleasure.
Can I ask a question, please, guys?
Yes,
Go
sir.
ahead, Mark, and that'll be our last one. We'll close up in just a moment here.
Okay, awesome. The intent trial that you're having in America, is it the same one that's going in Canada?
It is a little bit different. So in Canada, just because you have different regulators right?
Yeah.
So in Canada, there's the Focus Can study. So it does have a little bit, I believe it has one change with regard to inclusion criteria. So they are different studies.
Okay.
But they are essentially, like, as far as the cohorts of patients, they're quite similar in that we're not, and just like I had answered with Kathy, we're not looking at one form of ALS, but more understanding across the journey. Great question.
Okay.
Charles, just really quick, want to read one more question over to you, and then Galen, again, we can close out. So this is Brian. Hi, Brian. I've already spoken with a Synchron study site. Does that mean I'm in the pipeline?
Great question. So Brian, not every patient has to go via, like, enter a clinical trial. You don't have to enter that clinical trial via way of a registry. That's one way you can do it. There are typically also clinical trials listed by study sites. I'll share, I believe in the United States, we only have one study site that is active. So unless it is that one study site, and you can follow up with us via email, Brian, if you'd like, and we'll make sure to drop our emails in there. I would say, to be sure, I would definitely get yourself registered in the registry as well, just to make sure that you're in that consideration process. But if you have already talked to a study site, then you should be in good hands.
Chris, Charles, thank you so much. What an incredible hour. Just the technology, and then, Dr. Haithcock and how he lives the ALS world, and then he happens to be right at the center of all of this. It was very meaningful, and we really appreciate your being here.
Yeah, very much appreciate you, Chris, Charles. Thank you, everybody, for being here. I will put into the chat. It was a wonderful conversation. Really grateful for you, Chris and Charles, holding the space to sort of seed this conversation and these explorations, and working with patients and seeing how we can support independence and creative expression. We can continue these conversations on the site. There's always much more to talk about and more questions alive. ALS.Community. If you're not a member on the site, go ahead and join us there. We'll also be gathering, as we do every Tuesday evening, for the Connection Cafe. So that's just a way to connect with other members. We can continue some of this conversation. We can see what else is alive in the community. I know that we didn't quite have a chance to get to the question. One of the things that's on my mind still in this conversation is some of the various reasons there might be to pursue a method like this rather than something like an external cap that sits on the head. I know some of those technologies are also being developed, and I don't want to. I'd love to hear. I know we're just at the end here, but if there's anything you can speak to that, or we can continue this conversation on the site together. Chris, Charles, you have any response to that?
Yeah, I think to your point, Galen, it's a very exciting time in terms of the convergence of technology being developed for those who are living with paralysis. And I think one of the things that we are so encouraged about is that innovation begets action. And certainly as people and companies pursue different ways of doing things, the hope being that all boats will rise with the tide, and that we will continue as a whole develop technologies to try and support those that we want to serve. So certainly, I think it's a great opportunity for a separate chat on the forum in terms of some of the core differences. But nonetheless, it's very encouraging that not only is there a significant amount of innovation in this space, but there's also a significant amount of venture interest, and that these ideas are being funded to progress from a concept to reality, which is again such an exciting time.
That was beautiful. Well, thank you so much, and thank you for your engagement here, and for really doing this in partnership with the ALS community and keeping these conversations alive. Very much appreciated.
Pleasure was all ours, Galen and Jeff. Thank you, everyone, for attending.
Thanks for being here. Appreciate it.
Thank you, guys. Take care.
Bye-bye now.